So just to classify the GLP-1 agonist, on which I would be spending the maximum time, we have the short-acting ones, which is the exenatide and lixisenatide, which the half-life is less than 12 hours. Intermediate-acting ones, liraglutide, 12 to 24 hours, and the long-acting ones, the dulaglutide and semaglutide. And then there is a continuous-acting one, which has a longer half-life. So what do we have in India? It is good to know what's going on abroad, but we also need to know what we have in our armamentarium today. And these are the GLP-1 agonists which are available in India. We only have currently semaglutide, which is oral. We do not have injectable semaglutide, except for some patients which it can be ordered. So these are the things we have. We have liraglutide, which is once daily, dulaglutide, and semaglutide oral. So this is the first two are the short-acting ones. And of course, liraglutide is once daily dosing, which can be used. And dulaglutide is a long-acting one, which is once a week. So going into the data on obesity first, this is the data with the liraglutide, the classical scale study, which has been published. So initially, it was for pre-diabetic population. The scale 1 and 2, it was initially for pre-diabetic population. They were non-diabetic. It was only for obesity. And the BMI which was chosen in these patients were either more than 30 or more than 27 with dyslipidemia. So these were the patient group, and in the first scale study, 3,000 patients were enrolled, 56 weeks, and it showed almost 8% weight loss, which was very encouraging. And a few of those patients were then continued for 160 weeks more to see whether they would prevent the development of diabetes, because almost 86% of these patients had pre-diabetes. So there also, there was a weight loss of almost 6%. Then it was further studied in the diabetic group, 600 patients for 56 weeks, and the effects were almost similar, 6% weight loss over that. And then in various subpopulations like patients with sleep apnea and obesity, it has been used. There has also been a study wherein there has been a run-in weight loss with an aggressive diet modification, a very hypocaloric diet of 1200 kilocalories. So both the groups were given that diet, and then semaglutide, then liraglutide was given, and it showed that there was a 6% additional weight loss. So definitely efficacious drug over and above the hypocaloric diet. And then what about semaglutide? Semaglutide, there is, of course, the STEP trials, the phase 3 program, where the primary target was to see for the weight loss. And it was, again, across various subgroups in non-diabetic population, in diabetic population, and the dose was 2.4 milligram once weekly. So initially, it was given for 68 weeks, and then there was a 7 weeks follow-up where the drug was allowed to be washed away because it has a long half-life. And clearly, there was and mind you, these were all given in a graded manner. So they were started with 0.25 milligram, then 0.5 milligram, so every 4 weeks. So tolerability is a big issue. All these trials, the drugs have been increased gradually over 4 weeks, and around 16 to 20 weeks, they would reach their target. So again, significant weight loss to the tune of almost 15%, and almost 16 to 18 kgs weight loss across all subgroups, and also sustained weight loss over more than a year as compared to placebo. Coming to the Pioneer program, which is the data on oral semaglutide, which is what is available to us today. As Professor Sanyal just mentioned, that the weight loss is just as half. So if you look at the oral semaglutide data on obesity, almost 90% of patients had more than 5% weight loss, and 60% of patients had more than 10% weight loss. If you look at the Pioneer program, we don't have much data on NAFLD as far as this oral semaglutide is concerned, but weight loss, yes, 5% weight loss, almost 50% would achieve even with oral semaglutide. Not as efficacious, half as efficacious, but nonetheless better than placebo. There is reduction in waist circumference, and HbA1c reduction is also there, but yet it is not approved for weight management. Coming to the NAFLD data now, from obesity we move also to NAFLD data. Coming to these 4 important studies on liraglutide, the first one is the Armstrong et al., where 52 NASH subjects were randomized control trial. This is a classical lean trial which was published in Lancet. And there this was a biopsy proven study, placebo-controlled 48 weeks, where there was 39% resolution of NASH versus 2% in placebo. So significant effect as far as NASH resolution goes. 9% had progression in fibrosis in liraglutide group. Then there have been other studies in diabetic population. So this was in a non-diabetic population, which was mainly for NASH. And then there was 87 subjects studied by Feng et al. With type 2 diabetes and NAFLD, where again there was a reduction in intrahepatic fat. This was not biopsy, the biopsies were not done. There have been smaller other studies and one large randomized control trial of obese adults where they also studied the effects on the liver and found to have beneficial effects. Coming to dulaglutide also smaller studies, except the first one was with NAFLD on metformin, and the dose is 1.5 milligram weekly. The weight reduction with dulaglutide and liraglutide is not as good as with semaglutide. It is much lower, but definitely much better than placebo. And the weight loss is around 5% weight loss in 56% of population and 10% weight loss in only 7% of population with dulaglutide. But there was a decrease in liver fat content in patients which were studied with MRI-PDFF. This is the data with exenatide, where 16 newly diagnosed patients with obesity were studied and they were compared with insulin, and there was a significant lower levels of liver enzymes and significant decrease in body weight. So all these drugs have shown beneficial effects. Semaglutide, the maximum effects, lira and dulaglutide, little lesser effects than sema. So semaglutide this is the study Professor Sanyal mentioned about the Newsom et al., which was published in NEGM, 320 subjects with NASH and fibrosis stage 1 to 3, which was a randomized control trial, 0.4 milligram per day. There have been other studies also, and there has been one pilot study with oral semaglutide, 16 subjects with NAFLD. I'm spending few more minutes on oral semaglutide, that is because that is what is available with us today. So if you look at the last study in this, 14 milligram per day, 24 weeks, that is a 2.4% weight reduction, and AST and ALT decreased by around 25 to 50%. GGT decreased by 37. So again, very surrogate markers, not biopsy proven, so we don't know whether there was resolution of NASH or regression of fibrosis, but some beneficial data which is seen. This is the study which Professor Sanyal just mentioned in detail, the Newsom et al. NEGM study, which showed that almost 60% of patients with 0.4 milligram once a day semaglutide had resolution of NASH. So this was based on biopsy, the NAFLD activity score. There was resolution of NASH as per the definition in 60% of patients. The regression of fibrosis by one or more stages was seen in 43% of patients with 0.4 milligram semaglutide. But here, the placebo effect was also 33%. So it was not significant on statistical analysis. But 43%, I think, is quite a significant regression of fibrosis. I think even with bariatric surgery, that is what has been shown in most studies. Then there was other effects on body weight. We have just mentioned almost 13 to 15% weight loss over the study period. And there was an increase in HDL and decreased free fatty acids, triglycerides, and VLDL. So definitely a better metabolic profile was seen. HbA1c there was a reduction in HbA1c, but hypoglycemia usually is not a problem with these drugs. The major side effects were nausea, constipation. So GI intolerance is something which is going to be a major problem, and that led to drug discontinuation in some patients, not a lot of patients. Just one slide on GIP, GLP-2 agonist. This is tirzepatide, which probably has shown. So I'm going to the data of tirzepatide in NAFLD. So there was, again, these patients had, in the SURPASS-3 study, there was MRI-PDFF benefit shown. So there was a decrease, significant reduction in liver fat content, volume of visceral adipose tissue and abdominal subcutaneous adipose tissue compared with insulin. So this study is again mainly for obesity, but we also see that there is a beneficial effect on NAFLD and NASH. Again, surrogate markers as per these studies. Meta-analysis has mainly been with liraglutide and dulaglutide. The meta-analysis have not taken semaglutide, and again, just similar results which have been shown. Just highlighting two papers which were published, which were presented in ACG last year, and we had this best of ACG, so I'm just picking these papers, where they had these analysis, dual therapy with metformin and GLP agonist improves mortality in diabetic cirrhotic patients. So this was a study which was a retrospective cohort study from their database, and they found that the 3-year survival and hepatic decompensation, so these were patients who were type 2 diabetic, cirrhotic, and semaglutide was used to treat diabetes, and they found, not semaglutide, but GLP-1 agonists were used to treat diabetes, and they found that it had better survival effect. The all-cause mortality was low. And the 3-year survival in type 2 NASH cirrhosis patients, their difference was not significant. So the all-cause mortality was low, probably because of a better metabolic profile of these drugs. This was again another data which was shown GLP with SGLT2 inhibitors, and it showed a better effect in development of cirrhosis. So as a treatment in my practice today, where do I place GLP-1 agonists? A compelling indication where I would want to use is where I need to reduce weight, reduce appetite, reduce weight gain, and not have much of hypoglycemia, and reduce the cardiovascular risk. So when this kind of metabolic profile is there, these drugs would definitely have a role. But in my practice today, sitting in a city in India, we can probably use only oral semaglutide at incremental dose, which we have started using in some of the patients, in obese individuals with F2, F3 fibrosis. And we are a part of multi-center trial for injectable GLP-1 agonist in cirrhosis, if we can convince them to get enrolled. But right now, we are using in some patients oral semaglutide. Again, it's not conclusively evidence-based, the oral semaglutide, but we are using in some patients. Thank you.